Hello, friends, and welcome to T4, Tots to Teens Tidbits with Sagis. As you know, I am your host, Alana Bree, Dr. Alana Bree, and I am here with a dear friend who really needs no introduction, Dr. Tom Davis, who started all of this wonderful online teaching for Sagis way back when. And yeah, does his great board review class. When's it coming up again?
Oh, thanks, Alana. It's coming up on October 12th, Columbus Day. Mark your
Okay.
calendars. About 10 days or so before, we'll go ahead and release the slide deck and the questions. But I would encourage everybody to go ahead and register now and make sure that you're signed up to get the materials. And then, of course, like these, we'll record the session. So if people can't attend the live discussion, they'll at least be signed up to receive the recorded link.
Perfect. All right. Well, thanks again for being here. And we are going to be kicking off the second edition of the Pedi Derm CPC. We had a fun time the first time around, and we did cut down on the number of cases just because it was so much fun for me that I just seemed to talk a lot.
I had a great time.
It was fun, and we'll have fun today too. So, all right. So this sweet young thing came in to see me. Had been otherwise well, developed this lesion, was overall asymptomatic. She would kind of poke at it or pick at it every once in a while, but it didn't seem to be bothersome for her. She did not have any other skin lesions anywhere else. The family didn't think that they had started any new products. She didn't have any new exposures on the first time that I saw her. And I was really, to be honest, initially pretty stumped by this. I was like, okay, what could this be? And so I took a picture, asked mom, and this was back before it was such a big deal to share photos, but said, can I share, think about this a little bit and ask a few of my friends what they think, and then I'll get back to you. So that is what I did. I snapped these photos of this sweet girl and thought about it for a day or two, sent out some emails. And then if you were to biopsy it, Dr. Davis is going to show us what it was, but I had a light bulb moment and didn't need to do the biopsy. But if we did,
There we go. Usually in the dermis or sometimes in the deeper tissue, and frequently like this walled off by a little zone of fibrosis, one sees a mixed cell infiltrate. And in particular, we have collections of these pale staining cells, which on higher power can be seen to be epithelioid histiocytes. And some of these are multinucleated. These are forming kind of poorly defined granulomas. And in the center, we have abscesses, collections of neutrophils. So we have kind of a walled off zone of suppurative and granulomatous dermatitis. And why the most common cause of suppurative and granulomatous dermatitis that we see in the skin is typically due to a ruptured follicle or cyst. Obviously, in light of the clinical presentation, one always has to consider an infectious process. And so generally we'll order PAS and GMS stains for fungus, either an AFB or a phyte stain for a typical mycobacterium, and tissuegram stains as well. And in this particular instance, the stain we're going to be looking at is an AFB stain with a blue counter stain used. And if we look on higher power and focus in on the zones where we've got neutrophils or suppuration, in some of these spaces, lo and behold, and I'm going to get my pencil here and mark it, we begin to see these beaded acid-fast bacilli. And so these findings are most consistent with an atypical mycobacterial infection. And I'm assuming you did cultures on this.
yeah, we actually did not, mom really did not want her to have a biopsy on her face. And I really didn't want to biopsy this sweet young girl on her face
Sure.
because it's by her eye and it's really hard. You know, this age is really hard because they're just scared of everything.
Sure.
And it was right there by her eyeball. And so I sent it around and again was initially stumped, and I did feel like it was had that granulomatous look
Yes.
clinically as we talked about. And after I thought about it, sent it out, I was like, oh, this definitely could be a fish tank granuloma. And
Sure.
so I did ask, and they had gotten a new fish tank, and I think they had like a frog or an aquarium or something, and like the she was feeding the fish and she splashed it up in her eye kind of thing. You know what I mean? After questioning, I was like, was there any exposure? And then it's one of those, you have to ask those questions and know what you want to ask to get the information you need sometimes. And so, and then I asked around and everybody said, if mom's really hesitant, just treat. Clarithromycin is pretty well tolerated. So we did a more extended course and it did get better and she didn't have any other symptoms.
So,
And I do think that on her, because I've done this before, I did a PPD and it was positive.
hmm,
I've used that kind of as a
sure.
little test just to kind of see. And I'm pretty sure this is the one that I kind of did that on, and it was positive slightly.
Well, it's very interesting now to, in this case, when we identified microorganisms on special stains, we can go ahead and send the paraffin block for PCR. And so for these mycobacterial infections, we like to identify the particular organisms because it can help determine drug therapy response, et cetera. Did the lesion scar at all? A
It
lot?
really didn't. It went pretty, I mean, it kind of had a little divot, but it was in that soft tissue of her lower eyelid. So it kind of absorbed it a little bit. So you
Yeah,
really had to be looking to see it.
yeah.
I mean, it looked like if you got up on it, maybe a very mild, like chickenpox scar
Yeah,
almost.
yeah, yeah,
Yeah.
exactly. Maybe she should wear swim goggles when she gets near the aquarium now.
Yes, exactly. Exactly. But we didn't end up biopsying it. It got clinically better with the course of clarithromycin. And yeah, so that was a success.
Okay.
And yeah, this was back in the early 2000s. So
Good.
definitely didn't have that PCR.
No.
Yep. Okay. Jumping back on for our next case here. There we go. Okay. So basically, this was a kiddo we saw very young in the NICU, I believe, early on, had that kind of Linguno hair. You can see that, with that early newborn kind of fine hair. Um, we did end up doing a biopsy on this just to confirm. Overall blood work looked pretty good. And there is, I will tell you, a test that you can do that you want to check out when this is the diagnosis, a blood test. So, anywho, I will not steal Dr. Davis's thunder. So let me stop sharing here so he can show us what the biopsy
Okay.
showed.
And here in this particular instance, this wasn't from this patient, but the biopsy would show
Yes.
very similar changes. This was actually an excisional biopsy specimen, and as you can see from this lesion, these can be quite large. Correct, a lot large.
Yeah, this was pretty extensive. I mean, it was, I think, yeah, it was expensive.
So, in this particular entity, in the dermis, one can see we've got these nodular, what have been described as cannonball-like proliferation of vessels throughout the dermis, in this case extending as well into the subcutaneous tissue. And when we look at each of these individual lobules, you can see we've got capillary-sized vessels. These are very thin-walled vessels. They're lined by uniform endothelial cells. They do contain numerous extravasated erythrocytes and or erythrocytes in the lumina. And then at the periphery of some of these aggregates, you can see these crescenteric or half moon shaped vessels, which is pretty common in this condition. Another entity histologically that always enters into the differential, and this, by the way, is consistent with a tufted angioma, also known in the literature as angioblastoma.
Mhm.
But glomerular hemangiomas can actually have a very similar appearance. Those, of course, are associated with Poems and Castleman disease. But one distinction is that when you look at the lobules in the setting of the glomerular hemangioma, you see sequestration and degeneration of red blood cells. And these red blood cells all look fine. So that is one feature that you can use to distinguish the two. So,
That's so pretty. It looks like lace.
yeah, it does, doesn't it? It does. Yeah.
Oh, so pretty. I love microscopic images. I love doing this with you because of that. All right, so back to my screen here. You can see, yeah, it was quite extensive. It kind of extended up here, all around. If I remember right, it was kind of on the flank. And the association with this is, of course, Kasabach-Merritt. So this baby wasn't having any blood in the stools, urine. They had checked that. Otherwise doing well. Was admitted because of this condition, just to figure it out. But then platelets were normal, all the coags and everything were normal. So, and then the biopsy confirmed it, since it does have pretty pathognomonic looking path. So this little one was followed regularly, and did fine,
Okay. These don't involute though, do they?
No, they really don't. No. This diagnosis, you see this in this kiddo, you might do some dioscopy on it. And Dr. Davis is going to show what the patho.
Well, I don't even have to show the slide because biopsy of this condition yields a totally normal skin biopsy.
Yep,
Totally normal.
yep. So the difference is the Nevus, so this is Nevus anemicus, and the dioscopy is going to be positive when you hold the slide, basically, because it's increased sensitivity to catecholamines that block down the blood flow into this area, and so you'll see some blanching there, and yeah, so pretty easy to make clinically, so you don't even need to involve your trusty dermatopathologist.
And again, it's just going to be frustrating for them and us because the patient will have a scar and the answer is not in the
In the skin. Yep, exactly. If you don't know what the diagnosis is clinically, sometimes the biopsy may just not help. But yeah, we actually did some topical nitro paste on this, and it did seem to actually have a little bit of a benefit. It was hard to explain while we were prescribing it for a child. Yeah, we had to jump through some hoops, but it did seem to actually, I don't know,
Good.
do a little bit of something. And if nothing else, it was placebo.
Exactly.
All right, so next case. So this was a kiddo, and one was one was an infant, and one was an older child, asymptomatic, kind of nodules firm. And that's what these were.
Okay.
Clinically. And what does it look like under the microscope?
Let's go ahead and move on to our next case here.
Yeah.
And generally, these lesions, and you can see this was punched, and within the dermis, we have a nodular collection of cells here. Definitely looks more neoplastic and very well circumscribed, benign architecture. And out at the periphery, we have these very basaloid appearing cells. And centrally, we have these pink or kind of salmon colored cells. And it looks like there's some inflammation between the two. If we move to higher power, we can see we have collections of very basaloid germinative cells, high nuclear to cytoplasmic ratio, pretty frisky mitotic index. And as we move towards the more pink staining cells, we can see that it is these basaloid cells that are keratinizing losing their nuclei and forming these pink cells, which are known as ghost cells or shadow cells. And they have this distinctive pink, orange, or salmon color. And this is matrical keratinization. It's the type of keratinization that occurs in the inferior portion of the hair follicle as the cells of the hair matrix give rise to the hair shaft, and in particular, the hair cortex. These are actually, a lot of books classify them as a type of follicular adnexal tumor, but really what they are is a matrical cyst. And so, we have EICs or infundibular cysts that typically show differentiation towards the upper portion of the hair follicle, keratinized with interposition of a granular layer. Then we have pilar cyst or trichoepithelial cyst that keratinize like the middle segment of the follicle. Well, these are nothing more than matrical cysts. So they're a type of follicular cyst lined by matrical epithelium, which ultimately keratinize and form these shadow cells. Now, these shadow cells, like most forms of keratin, are very pro-inflammatory. So you tend to get a lot of inflammation within the surrounding dermis. These cysts will tend to rupture, which gives you the nodularity that you know clinically. And as you can see here, these shadow cells have a propensity to calcify. And so in mature pilomatrixomas, what one sees are keratinized shadow cells, which can then serve as a nidus for ossification within the stroma. So it's a fascinating lesion in that the histology changes drastically over time. But the tendency to calcify and ossify explains why they are so firm. I've noticed, I'm sure you have too, Dr. Brady, when you get these out, sometimes you get just chalky fragments.
Yes. Yeah. Yeah, they're kind of fun to get out though. And this, these clearly had that kind of teeter-totter sign that they tend to have clinically, usually asymptomatic. And yeah, I like to kind of just go over the top of them and size over it and kind of try and get it out without, and just put one little stitch once you kind of flush it a bit. They're fun to shell out, but they can kind of, disintegrate.
Mm-hmm. And they can get pretty big, can't they?
Oh yeah. I mean, this one on the back, going back to the scalp picture here.
Let me stop sharing. Mm-hmm.
Yep. Let's share. So yeah, this one was pretty big, really, on the scalp. And again, they have that classic firm papule. And there's really nothing that feels exactly like them clinically either. They usually are very well demarcated feeling. And again, they can be associated with gene mutations in beta-catenin. And then it's that overactive proto-oncogene with suppressed cell death, and all of that good stuff is kind of the pathway for that. So the board say like to ask is beta-catenin for the gene mutation. Or at least it used to be. I don't know. Dr. Davis can clue us in. Is that what they still like to ask?
I do believe, yeah. Mm-hmm.
Yep. All right. So what is this diagnosis? Usually it can be made clinically. And I will tell you, it started out on this young one's abdomen, and then progressed to these really itchy papules over the elbows and the knees. And then they actually started coming up around the forehead, the edge of the forehead. And she even had some on her dorsal wrists and hands.
Okay, let's go to our slide deck. And in this particular instance, shifting gears, we've got a bisected punch biopsy. And one can see that we're dealing with an inflammatory process, rather than a neoplastic process. There is a superficial perivascular infiltrate within the upper portions of the dermis, and there's overlying epidermal hyperplasia. So we've got a little bit of a psoriasiform dermatitis, but as we zoom into higher power, we can also see there's spongiosis leading to the formation of microvesicles in the epidermis with widened intercellular spaces, some extension of lymphocytes into the overlying spinous layer. So what we've got here is a spongiotic psoriasiform dermatitis, which is the classic histologic appearance for a subacute spongiotic or eczematous dermatitis. And within the dermis, we have an infiltrate of lymphocytes, and there are also scattered eosinophils. When you see those, one of the things you think about are contact dermatitis, contact dermatitis. Histologically, distinguishing subacute contact from nummular from an id reaction from a spongiotic drug is really difficult and not impossible. So in this particular group of disorders, it's critically important to correlate with the clinical findings and history.
Yep, a great case for CPC for sure. And I think most people would diagnose this clinically for the most part and not have to grab a biopsy in this case, just because it's so localized here, which of course, jeans, snaps, buckles, all of that on pants. And then this little one had an exuberant id reaction. She really did like jewelry. The pediatrician, of course, when she had this, said you should stop wearing metal. So they did that. And it progressed, and she did have to be on a nickel-free diet because she started developing this id reaction very classically over the elbows, knees, dorsal hands, and around the forehead. And I will tell you that I have recently contracted contact dermatitis from Lumi deodorant, the unscented that is not unfragranced. And I would highly recommend avoiding those all over body spray deodorants because of the fragrance. So now I am allergic to balsam of Peru, cocamide DEA, lots of good stuff, lanolin, and I actually developed an id reaction on my elbows. So I submitted to the extended patch testing with Dr. Cotta myself, and we figured it out, and luckily much better. But I had to do the balsam of Peru avoidance diet for 8 weeks, and I thought I was going to die. That is not a fun.
No, I was going to say a lot of these components of fragrance are in foods, and so
Yep.
you don't want to get a systemic contact dermatitis.
Yeah, so that's what this is a systemic contact dermatitis. I have lived it out myself. And that balsam of Peru avoidance diet, they sometimes like to ask about that on the boards, and I can tell you what it is personally. You cannot have cola. Diet Coke is one of the colas you cannot have. That was rough. Vanilla, clove, citrus, tomatoes was another big one on that list. So those are kind of the main ones that are on the balsam of Peru avoidance diet. So not easy to do for your patients, but essential if you're trying to kind of figure things out. Luckily, I am still allergic to cinnamon, and I had a positive reaction to cinnamates as well. So I'm still avoiding cinnamon, but I added back in all the other things that we talked about. So thank goodness for that. All right, so this patient came in, otherwise healthy, did have some other medical conditions that we're not going to talk about right now because we don't want to make it too easy. And this young one had this lesion pretty much asymptomatic, a little itchy again, maybe painful when I ask about it, but really overall pretty asymptomatic that was getting a little bit bigger. And a biopsy of the lesion showed something very similar to what Dr. Davis is going to show us now.
Exactly. In this particular condition, and here we've got a very nice, robust punch biopsy. One can see the subcutaneous tissue down here. Obviously, this is a fairly deep process involving the mid to lower reticular dermis. And the thing to note about this condition, we've got a lot of inflammation here in the dermis, is that it is top to bottom, side to side. So it's a nodular and diffuse dermatitis. And with any of these conditions, what our differential is predicated on is identification of the cell type. So this has a vaguely layered appearance. You can see we've got inflammatory cells, a zone of altered collagen, some inflammatory cells, a zone of altered collagen. Has kind of a layer cake look. if we go down and take a look around the vessels in the dermis, we have lymphocytes. There's a rare plasma cell within the infiltrate. And one can readily see we've got a lot of epithelioid histiocytes. Many of these are multinucleated. There are some eosinophils and lymphocytes within the dermis. And then sandwiched between these layers of histiocytes, we've got zones of collagen, which is degenerating. The discrete collagen fibers are not so easy to see. Another linear layer of epithelioid histiocytes, some more degenerated collagen, and so on. And so these findings are very characteristic of necrobiosis lipoidica. It's also starting to extend down into the fat. And when NLD extends from the deep dermis down into the fat, one sees widening of the septi. It's a septopeniculatus. So,
Yeah. And now I am hungry for layer cake.
yes.
All right. So NLD, again, has been associated with type 1 diabetes. And 1% of people with this condition do develop it. This kiddo had struggled with diabetes for quite a long time, getting into the teen years, and had developed this lesion. So fits with kind of the classic situation.
Yeah, one thing I'll point out, at least from a histologic viewpoint, Alana, sometimes, people will, you can sometimes get these erythematous papules, kind of early NLD type lesions out at the periphery. And obviously, one of the histologic differentials for NLD is GA, because you get histiocytes palisaded around collagen, and both can occur in the setting of diabetes. And
Yeah.
so sometimes I've seen the coexistence of the two. And so sometimes when you biopsy these papules right up near the edge, it initially will look more GA-like. So anyway.
So fascinating.
But
So
it kind of makes sense. Yeah.
Yeah, it does. It actually makes a lot of good sense. All right. Yeah, that yellow color makes you lean more toward the NLD than the GA, but certainly, like they say, lesions don't read textbooks. And sometimes, yeah, some things are good with, a punch biopsy giving you the answer, and some things are not. But
Actually, it's a very similar color, the red to the first case, the atypical mycobacterial infection.
it is. You're actually very correct on that. Okay, let's see if we can get this to go forward. There we go. Okay, so this little one has a biopsy sign. Otherwise healthy. This was present at birth. It was biopsied in the hospital as a consult. I did not see the baby in the hospital. Another one of my colleagues did. And when the baby came in, mom said she thought it looked actually less red, less swollen. And I think this baby was about 2 weeks of age when I saw him in the clinic.
And as is frequently the case with these, they tend to fragment, the biopsies can be kind of difficult to obtain. And one can see in the dermis, we have these very cellular nodules here. And as we move to higher power, you might be thinking, what's going on? What type of tumor is this? But as we move into higher power, we can see several dilated vascular spaces containing RBCs. They're lined by endothelial cells. And then out in and between the vessels, we've got a proliferation of endothelial cells. And so we've got a very highly cellular vascular lesion. There's no real cytologic atypia, but this histology is very, very characteristic of a congenital hemangioma.
Yep.
And, initially, whether they're rapidly involuting or non-involuting, you can't really tell. You just got to follow them over time, histologically, I think, and clinically.
Yep, exactly. And of course, both of those congenital hemangiomas, the rapidly involuting, the non-involuting, they're both known to be GLUT1 negative. as far as staining. And again, this baby was already, you know, getting better. The lesion was already starting to actually involute at 2 weeks of age. So that was reassuring. But yeah, most of these do get biopsied just because of the potential for tumors. And that was definitely what they wanted to rule out when, you know, when the person saw the baby for a consult. But good news for the family. And this did leave a pretty nasty, scarry looking lesion that wasn't very pretty, that hopefully as the child grew into it would get better, and maybe laser for surface. But I wasn't there long enough to see this little one grow up to that point. So
You can get quite a bit of atrophy, can't you, as
oh
these?
yeah, they can divot deep, like yeah, for sure. Yeah, very impressively. So yeah, that is just having the evolution of knowing what we know about hemangiomas over time has been so nice. You know, Dr. Frieden and that whole
Yes.
crew that started all that hemangioma work, and now there's the whole hemangioma working group that have really helped define a lot of things that have really changed the face of diagnosis for hemangiomas. And then also with propranolol coming around, it's changed treatment too significantly.
Exactly. And it obviously can be a source of anxiety for the parents. So with more scientific data, it's easier to counsel them too, I'm sure.
Oh yeah. Oh yeah. All right. So this kiddo, I was in St. Louis at the time, and our Mohs surgeon was on a mission trip, I think to Ecuador. And here comes these pictures to my cell phone. What is this? This is out of my league.
Yeah. Yeah.
So if a biopsy was to be done of one of these areas that's telangiectatic and, you know, it can
Yes. Let's
hyperpigment.
go ahead and go to our next slide.
Yep.
And what one would see, let me go ahead and tilt the slide here so we can look at it and get our orientation. Okay. In this particular shade biopsy, which has been bread loafed, in this particular condition, what one tends to see is epidermal atrophy. Okay, the epidermis is a little thin. One can see effacement of the reedy ridges, and there's pigment incontinence in the underlying dermis, melanophages, all occurring in concert with dilated vessels. And so typically biopsies of this condition show poikilodermatous change, hypo and hyperpigmentation, atrophy, and telangiectasia.
Perfect. Yeah, so this one is definitely a clinical pathologic correlation because that isn't a slam dunk.
No.
Um, so basically you do have to know the CPC is important. So this was Rothmund Thomson, which is an autosomal recessive condition. It's a RECQL4 mutation, and the big board questioner used to be is osteosarcoma is the association. So those are kind of the highlights on Rothmund Thomson, and definitely, you know, poikilodermatous clinically and histologically, but then putting it all together.
Yeah, it's a very unfortunate. It presents pretty early in life, doesn't it?
It sure does. It sure does. Yep. Yep. And
Mm,
yeah, and then being in a country where there's not a whole lot of support
no.
makes it very challenging. All right, this is something a little bit easier to diagnose clinically and histologically. But again, probably a little bit of, you know, broad findings under the microscope that may not give you a slam dunk, but when you put it together, you can usually make this diagnosis pretty easily.
Okay, so quite frequently in this condition, as Dr. Bree pointed out, you can have variable histology, but you can see we've got I'm going to focus on these particular images, you can see we've got a shade biopsy from a volar surface, very thick stratum corneum here. And we've got an intraepidermal vesicle. And generally, when we approach intraepidermal vesicles, we tend to classify them based, among other things, on the mechanism of formation. And this particular vesicle is formed as a result of spongiosis. You can see widening of the intercellular spaces, producing this vesicle. And within the vesicle here, we have kind of a mixture of inflammatory cells. We have lymph, but we do have a few scattered neutrophils, especially near the epidermis, where there are a few necrotic keratinocytes. So from my perspective, again, in the absence of clinical data, we would give you a report that said that this is a relatively acute spongiotic dermatitis. And considerations would include things like dyshydrotic dermatitis, nummular dermatitis, not so much nummular, dyshydrotic contact and aid reaction. And of course, we're always in spongiotic dermatitis on a volar surface going to check a PAS to make sure there's no dermatophyte. And the PAS was negative here.
Good point. That is a hugely important point. And this can become secondarily infected. So the underlying condition is juvenile plantar dermatosis, pretty classic here with, you know, the sparing of the arch, and then you have it on your heel and on the the forefoot, and then also with the cracking and fissuring. You do want to make sure there isn't secondary infection, but usually it's really just so inflammatory and so spongiotic that it's just goopy and oopy from the underlying process. So really, this is a tough one. Some kids have hyperhidrosis with it, so you have to treat the underlying hyperhidrosis that makes them a little prone to it. Some of them are, you know, more just because of the excess sweating. I will tell you, those Croc shoes and those native shoes are the worst for this. Yeah, just because it makes them all sweaty and yicky and nasty. And then, you know, strong topical steroids when it's so inflamed. I like to do soaks. I love Don Burrows soaks for, you know, anything that would be spongiotic, including this. Just put, you know, some wet socks on for the little kiddos. But yeah, it's usually not a hard diagnosis to make clinically, but it is more challenging to treat sometimes because of the recurrent nature. But that's what this is. I got to review the world literature. Dr. John Browning out of San Antonio and I, when he was a fellow at Texas Children's, wrote the chapter on juvenile plantar dermatosis. So anyway.
Do you usually routinely culture these?
I do, just because I'm a culturer because it's a swab, it's easy, and it gives you more information, and maybe you're over treating sometimes, but I'd rather have a culture and sensitivity. Like, I rarely treat empirically with antibiotics in kids. I'd rather, you know, get the culture, do some things to make them feel better, wait for that to come back and see if we really need to add on any other treatment.
Yeah, because I'm sure in this location too, you can occasionally get gram-negative organisms, you know, gram-negative toe web infection.
Yep. Exactly. So
and do the kids tend to outgrow this?
they do. Yeah, yep, definitely. Just like the eczematous conditions. And it, you know, it's more common in kids with underlying eczematous dermatitis. All right, let us go to the next case. So this sweet girl had these lesions that were increasing with age. And as you can see, she's also got some comedones on her nose. So she became more conscious of these lesions as she got a little bit older. And this you can kind of guess, but it's always good to confirm with pathology, I think, in these cases.
Exactly, because you know there are any number of tumors that can occur in that location. Okay.
Yep.
Go ahead and get our biopsy here, and we've got a bisected shade biopsy here, and obviously there's an infiltrate in the dermis. As we move to higher power, we can see we've got this dome-shaped papule, and within the dermis, we have an epithelial proliferation, okay? And it is composed of these Basaloid aggregates, some of them with a cribiform or sieve-like pattern, and horn cyst. And the entire lesion is embedded within an extremely fibrotic stroma. You can see that there are clefts present within the stroma and between the stroma and the surrounding dermis. But if you were thinking about basal cell, because there basal cell carcinoma, there is some peripheral palisading. There's no clefting here between the basaloid cells and the surrounding fibrotic stroma. In addition, we do have a few collections of fibrocytes or fibroblasts investing some of these basaloid aggregates. And these structures are known collectively as papillary mesenchymal bodies. And when we see these in concert with the other findings, the changes are diagnostic of a trichoepithelioma.
Yep. It's a pretty biopsy too.
Very pretty.
Yep. So trichoeps, and you can get familial multiple trichoepitheliomas. Brooks-Spiegler is the other, genoderm that is associated with that. And then, the cylindromatous gene tumor suppressor is what is involved in that. So, and this sweet girl ended up being able to come to Camp Discovery through the Academy of Dermatology because she was so bothered by them. And there's really not a whole lot you can do. We tried a few different things, desiccating, TCA. Yeah, they're just really hard to treat. There's really no treatment. Treatment is going to camp if you have a kid with them.
Did she have a family history?
No, she didn't.
So it was a sporadic mutation. Huh?
Yep, it sure was. Yep. All right. So this is something that we see probably more commonly than, we ever diagnose it. And it could be, you see these atrophic kind of macules on the skin. They do tend to be around the eyes, on the, facial lesions. And as far as the biopsy, we will see what it shows, but I suspect it's not very impressive.
Yeah, exactly. Okay. Let's move to our next slide. And in this particular condition, and a lot of times you have to get multiple levels to see the characteristic changes, but quite often, and this is kind of a little at the edge, we have a dilated follicular infundibulum, and it's widely dilated with a keratin plug. And if we were to cut a section, you would see that this was fairly dilated, which corresponds to what you're seeing. And then usually around the deeper portions of the follicle, you'll see a lymphocytic infiltrate. And so the biopsies of the various forms of keratosis pilaris tend to show this type of change.
Yep. And so there's that whole list of those type of conditions that kind of hang out together in a family, with the atrophic nature of these. And she hadn't had chickenpox. She hadn't, had any acne there. They developed on their own. So this can be a familial trait. It is the mode of inheritance is autosomal dominant. It's the LDL receptor related protein 1. I had to look that up and read it off my paper. But that is what it is associated with. And again, autosomal dominant inheritance if it's familial.
Okay.
All right, let's go to our next slide here. All right, so I had a faculty member that always loved to ask this question. So this is a lesion. They can be multiple, they can be single. I love what it looks like under the microscope, so I'm excited for Dr. Davis to show us what what we have.
Okay, we'll get to this one pretty quickly. And they're beautiful biopsies. You might think you're looking at a normal ear biopsy. And so we usually have this polypoid lesion that corresponds to what we were seeing clinically. You can see there is a normal appearing epidermis. We've got a lot of vellus hair follicles embedded in the dermis. trending down towards the subcutaneous or fatty tissue. And then we have a cartilaginous remnant in the center. Sometimes you don't see the cartilage in these. You may just have fibrofatty tissue centrally, but when we see this configuration, we know we're dealing with an accessory tragus.
Yep. Yeah, so pretty. And it does correlate. Like when you're excising these, you know, you don't have to, but a lot of these kids want it when they're older to be removed.
Mhm.
And, you know, a lot of people just lop them off at the base. And you can see with this slide here that if you don't get that cartilage,
Yeah.
yeah, you got a problem potentially, and it's not going to heal as well and all that. So it's really, I love dissecting these out. Dr. Annette Wagner showed me the tricks to do it with your little iris scissors, but you just lift that guy up, you know, and you get in there, make a little ellipse around it, and then you follow that little cartilaginous tag all the way down. And once you get to the bottom of it, it's just like, boop, you know, when you hit it.
Yeah, exactly. I would imagine at that location too, if you don't get it out, probably sometimes I'm sure you can get transepidermal elimination of the
Yep.
cartilaginous fragment. So
Exactly. You just need to stay really close to that car, just stay right along it so that you don't damage any other structures and, you know, that. So the question that always got asked is if you had a child who was deaf that didn't pass a hearing screen when they were a child, what syndrome would you consider if they had an accessory tragus? And it's golden heart syndrome, also called ocular auricular vertebral syndrome. And it's an autosomal dominant inheritance. So that is that, and all the little board pearls that can go with it.
great.
All right. And this, I did end up, this was a baby, still in diapers. And it was just a lesion that we could not get rid of. It drove me kind of crazy, you know, and with pediatrics, we tend to do therapeutic tests before we jump into doing the biopsy because the
Sure.
kid don't want to be biopsied. You don't want to biopsy the kid. And so otherwise healthy kiddo, this was the only lesion in the diaper area. And we did end up using some higher potency topical steroid on this as well. So you can see that it almost looks granulomatous, you know, but here it was a little bit of atrophy and it had already starting to flatten out, but we still biopsied one of these bigger papules here.
Biopsy I have, I actually had to pull one offline, Alana, because we didn't have one in our file. But typically in this condition, and it's not a surprise given what you see clinically, you tend to get quite a bit of epidermal hyperplasia. It can be kind of dome shaped, so we kind of have this psoriasiform dermatitis. The keratinocytes, of course, show evidence of orderly maturation, and usually you have papillary dermal edema, and it tends to be associated with a mixed cell infiltrate. Usually a lot of lymphocytes, sometimes a few eosinophils, neutrophils, plasma cells. Everybody is invited. And again, in this situation, we'll always get a PAS looking for Candida or dermatophyte, and typically these are negative. But psoriasiform dermatitis is particularly common on biopsies.
Yep. Yep. Yeah. And this was a one and done case for me too. It was the only one I've ever seen in my career. I'm glad I snapped a pic of it. Because when you look at it, you can kind of see that it is pretty classic clinically, but again, it wasn't getting better. So that's always time to consider doing a biopsy, even in peds, if you don't want to do it. If things aren't going your way, then you need to, and you can't figure out a different course and get it better, it means you should probably biopsy it. So yeah, they think it's just kind of this inflammation, maceration in the diaper area, the recurrent nature of it, and then use of fluorinated steroids can also induce it. So
Granuloma glutale, obviously.
yep, yep,
I've
yep.
also seen it, in older patients who have been bedbound, and
Yeah, they can get it as well. You're right. Yep, that's the ends of the spectrum can
yeah,
be very similar in a lot of ways.
yeah, yeah.
Very similar in a lot of ways. Yep. Yep. But granuloma glutealum infantum. I don't know. I've never been good at pronouncing things. I probably shouldn't have picked derm in some ways. Luckily in derm, there's like 10 names and you can usually pick one that you can pronounce.
A lot of acronyms too.
Yes, exactly, exactly. All right, so this kiddo came in otherwise a healthy, I think he was about in 3rd grade, I wanna say,
Mm.
and was headed back to school. They had gone on a big vacation, and then went back to school. Mom thought that he was maybe nervous and picking because he tended to be a little bit more anxious child, but I was like, "I don't think he's picking." And this we did a bedside test, but if you did do a biopsy,
Yes, if you did do a biopsy, what you would see is something like this. And here we have a punch biopsy. This was from near the hairline. You can see we've got terminal follicles here embedded in the fat. And if we look at the top piece, we can see there's a pretty brisk perivascular and somewhat nodular infiltrate around the hair follicles and the vessels. Looks like it's composed predominantly of lymphocytes. And in this particular condition, we tend to get kind of this dense lymphohistiocytic infiltrate within the dermis. The telling and most diagnostic features are in the bottom piece. And here you can see we have an intraepidermal vesicle. I think even at scanning magnification, one can see there's extensive necrosis of epidermal keratinocytes and also of follicular keratinocytes. Moving to higher power, we can see that the blister is formed as a result of acantholysis. So the cells are separating from one another. And there may be a little bit of ballooning in some areas as well. A lot of these cells are not viable, but if we look in the epidermis, we can see remnants of multinucleated epidermal keratinocytes. These are acantholytic. Let me cancel that. And you can see 1, 2, 3, 4 nuclei. So we have a later lesion here of herpes virus infection. And when we start to see pronounced extension into the follicular unit, while not pathognomonic, it's much more characteristic of zoster than it is of herpes simplex. We can also do IHC stains to determine whether we've got a herpes simplex virus infection or a zoster infection.
Yep, and PCR is so easy to do nowadays. Like before, yeah. And again, before it was just really the culture and culture. If you get an older lesion, is not going to be so positive. And yeah, we did a zinc stain that was, had many multinucleated giant cells.
Or a Zank smear. I remember doing Zank smears.
Thanks. Is that what I said? Did I say KOH?
You said PCR.
Oh, yeah, you can do PCR, but yeah, we did a zinc that day in clinic and it had many, many multinucleated giant cells. Yeah, and you can see here, it's kind of that, and again, we talk about dewdrop on a rose petal for varicella more, but it's definitely got those clustered vesicles with the rim of erythema, the, erosions from the vesiculation. And you can see that going on here, and it's in the classic V1 distribution. So with zoster, you definitely in V1, you want to have their eyes evaluated. Luckily, dermatology and ophthalmology shared the same building, so we walked him over. We got him started on acyclovir orally, and then brought him over to the clinic. And they felt like his eye wasn't involved, but they did close follow up with him.
Right here too, Alana, I'm just going to point out real quick. Here
Yeah,
we've
you want
got
me
our
to?
characteristic
Ooh,
viral cytopathic change. So you see we've got
yeah.
margination here with the chromatin rimming the periphery, giving this steel gray appearance. Multinucleation here as well too. Maybe getting a little early molding there, the 3Ms
Oh
characteristic.
yeah,
Um,
that's pretty.
for sure. I take it had the kid been vaccinated or did he have varicella before?
He actually had wild type varicella. So this was early on when the varicella vaccine was first coming out. So kids still were getting chicken, not pox, not a lot, but it was early in the day. So, and I will tell you, since that time, I have seen some cases that really post-vaccine look just like they would have had the wild type varicella.
Really? Wow.
Yeah, I
Wow.
really have. I really have. So, um, yeah, it's really interesting those kind of post-vaccine breakthroughs and,
Yeah.
but it does, overall have less morbidity in the cases and less negative sequelae. So worth
And
doing.
the incidence of postherpetic neuralgia in kids is quite a
It's
bit
pretty
lower.
small. I don't know what the percentage is,
Yeah.
but it's not usually a typical feature. I
Mhm.
didn't do steroids, and that's controversial anyway, oral steroids to prevent postherpetic neuralgia. But once it healed up, he was just really more worried about having to go to school with it. So I think he just wanted a note to wear a baseball cap to school.
Exactly. And obviously, we know with zoster, you're not one and done. I mean, he could easily get it
Get
again.
it again. Yeah, and even babies can have it. A lot of people don't realize that if mom got exposed, the baby can actually be born with congenital zoster, depending on exposure. And of course, they can have a host of other issues depending on how severe it is, because it does cross the placenta. So anyway, it's not as uncommon in children as people might think. And, you don't really have to do a big workup for immunosuppression. Of course, I asked the questions, lots of infections, rare infections, blah, blah, blah. But if that's not the case, you don't really need to get all up in arms about it.
Okay.
Yeah. Okay. So this one should be a fairly easy diagnosis under the microscope.
Mhm.
I think clinically it has some features. This was one of my very first cases of seeing this clinically as a resident in my resident clinic, and I did excise it. She was very happy to get rid of it because everybody thought it was a booger. Um, so she was happy to get rid of it. And it showed classically what we suspected under the microscope.
Exactly. So you can see we have a dome-shaped papule, which we saw clinically, fairly dense cellular infiltrate within the dermis. As we start moving into higher power, you can already see we've got a mixture of inflammatory cells here. There are clearly some lymphocytes, small dark cells, and there are some cells that are quite a bit larger with pale staining cytoplasm. As we move in addition to lymphocytes and a few eosinophils, we begin to see that we've got foam cells, lipid-laden histiocytes. Some of these are multinucleated, and in areas one can see evidence of the classic Teuton giant cells with kind of a dark peak center, variable number of nuclei surrounding that, and lipid out at the periphery. And of course, these findings are very characteristic of a xanthogranuloma.
Yep, yep. So juvenile xanthogranuloma, and they are S100 negative, right?
Usually, some of the early ones you can get a little bit of S100 staining, but
Okay,
it's focal and patchy.
okay. Yeah, it's not so bright like a typical Langerhans cell.
Yes,
Since this one is a non-Langerhans
right.
non-Langerhans cell histiocytosis, the JXGs are. Yeah, but that's interesting because that's interesting to know you can get patchy.
Patchy staining, they will be negative with CD1A and
Okay, so that's
CD207, which are a little more specific. So, but
okay.
yeah.
All right, all
And
right.
clinically, in that one, you'd also consider a Spitz Nevis too, wouldn't you?
Yeah, absolutely. Yeah. So yeah, circling back, it's got that kind of yellow pink color
Mhm.
and it's got the telangiectasia, which isn't as common, but Spitz is always in the differential of these lesions for sure. So if you have JXG on your on
Yeah,
your pass sheet, you should probably have Spitz nevus on your pass sheet. And I suspect that's the case most of the time you get one of these biopsies.
yeah, for sure.
Yep. All right, so this case, very interesting case. Not so interesting for the sweet girl who had it. So underneath the microscope, you will find evidence, but a lot of it is clinical. You see this atrophic hyperpigmented lesion with indentation. It's asymmetric. She actually has deviation of her tongue and her uvula as well to that side. So This is pretty classic clinically, but under the microscope, we can always get some further information.
Yeah, exactly. And I have a biopsy from a patient with this condition, but not this particular patient, as you'll see momentarily. Let me go ahead and rotate the slide. The specimen is from pretty severely sun-damaged skin. You can see we've got a solar elastotic band here. So this has been a long-standing lesion. And, you know, the most striking changes are obviously present in the deep reticular dermis with extension into the subcutaneous tissue. And you can see we've got very thick, hyalinized, and sclerotic collagen bundles in the deep reticular dermis. And much as I indicated with NLD, when morphia extends down into the subcutaneous tissue, you tend to get a septal paniculitis. And you can see here the septi are very thickened and sclerotic, and a lot of times the sclerosis will extend down to and involve the fascia. So I don't know about you, Alana, but when I've seen these cases, it tends to be a very deep expression of morphia, more morphia profunda involving the fat and the underlying fascia.
Yep, exactly. So linear morphia, you know, and that's more classic in childhood. You can get your Incupt Sob, and that, you know, can have neuro symptoms. It's important to get neuroimaging for those kids. And then here you get deviation of the tongue when it's on your lower face. And then I had a terrible case of the pansclerotic type that just withered this sweet little girl's arm. It was contractured. It was horrific. There are better you know, nothing FDA approved for those rapidly progressive. And I mean, it happened quick, you know, and, you know, we admitted her back in the day, the pansclerotic, the one that involved the entire arm and kind of side of the chest. And we did high dose methylprednisolone IV for 3 days, had to be monitored in the step down unit. And then we started methotrexate with that. She did improve, but you know, once the damage is done, the damage is done. I did have an Incupt Sob patient that we did end up injecting collagen into underneath the lifted up. No, yeah. What was the filler? I'm so out of touch with fillers.
The old sculptor or no?
It was even before Sculptor. What was the name of that?
Zyderm?
Yeah. So
Is that
some of that we had put.
collagen? Yeah.
Yeah, and it actually looked pretty good after, but, you know, we talked about it could inflame it. Again, this was an Incupt Sob case, and I had another one locally that was done by a Mohs surgeon here in town in Houston. Dr. Meir helped me out on that one because I wasn't going into the OR after that. But yeah, and this one did pretty well with a little bit of collagen in it. But you want to make sure the process is pretty burned out, and I, you know, always counsel them that it may reactivate things with the trauma, but anywho. All right, I think we are getting, do we have another case? Or
That's it.
that's it. So we got to the end and we did it in a pretty timely way, I have to say, at least for me.
Yeah, it was fun. It was fun.
Yeah. So if you want to give another shout out about the board review.
For exam review, again, will be before the next offering of the DermPath Core, October 12th. It's a Saturday. And I'll be joined by Emily DeSantis. She will be my co-host this time. Excellent educator, excellent teacher. And again, even if you're not planning on attending the discussion, please go on and register so you can at least get the materials. And again, the session will be recorded, and anybody who registers will get some resources. We've got some journal articles pulled, the question sheet, the link to the slide deck, and then after we record the session, you'll also get a link to the recording. So hope you'll be able to join.
Yeah. And then we also have an announcement on the T4 side of the world. We are going to be launching a new session. I'm really excited about it. I think the patient voice is highly important when we're training as physicians. And we don't involve them enough sometimes in just even the medical decision making, the research. And again, We got to know what they're thinking. So I'm really excited about T4P2, the patient perspective series of T4. We're going to be having different groups that are part of the Coalition of Skin Diseases come, and we'll have dermatologists and patients affected, parents. But we're going to be kicking off with Kelly Barta, the executive director of the Coalition of Skin Diseases, for our first one on September 19th. And she's going to be talking about advocating for those with skin conditions. And I will tell you, being involved with the Coalition of Skin Disease on their board as a member has just been such a joy, because it's really a great collective of patient advocacy organizations and amplifies our voice. And there's 84 million people in the US that have skin disease. So it's nice to have a collective within our dermatology world to support those things. So very excited about that. September 19th. We'll hope that you'll tune in or check it out afterwards. And thank you to Dr. Davis. Again, this was another fun CPC edition 2, and we already got edition 3 in the hopper, y'all. So more to come.
Good. Okay, well, thanks so much, Alana.
All right. Thank you. Have a great night.
Hope everybody has good evening. Take care. Bye.
All right.